Standard hypnotic drugs do not create sleep. Treating insomnia with generic blanket sedation simply induces a state of medicated unconsciousness. To actually restore physiological sleep, clinicians must isolate the exact point of failure across a rigorous three-tier diagnostic matrix. This diagram outlines that matrix. Tier 1 is sleep continuity and duration, whether a patient falls or stays asleep. Tier 2 maps internal microarchitecture, the cycles of REM and slow-wave sleep. Tier 3 expands to the overarching 24-hour circadian biological clock. Bypassing generic symptom suppression and mapping chemical interventions strictly to these three specific tiers is the only way to achieve true pathogenic correction. Treating Tier 1 requires strict adherence to pharmacokinetics. The clinical rule here is exact. You must match the drug's half-life curve precisely to the physical point of disruption on the sleep timeline. The most common mechanical failure at this tier is sleep onset delay, a pure inability to cross the threshold into sleep. This chart models the correct intervention. Short-acting agents like Solpadem spikes rapidly to initiate sleep, then clear the system early. Conversely, misapplying long-acting doxylamine extends the curve far past the wake marker, guaranteeing next-day cognitive impairment. The opposite mechanical failure at Tier 1 is early awakening, where a patient wakes up hours before dawn and cannot return to sleep. This requires the inverse approach. Agents with an extended half-life, like mirtazapine or amitriptyline, must be deployed to maintain steady concentration throughout the entire night, only tapering off as endogenous wakening mechanisms trigger. While precise pharmacokinetic matching prevents morning hangovers, it remains a symptomatic fix. Resolving the insomnia entirely requires pairing this timing with a pathogenic approach to fix the underlying chemical driver. A pathogenic approach utilizes the specific, often off-label neurochemical properties of a drug to neutralize the exact neurotransmitter causing the wakefulness. For example, patients who cannot fall asleep due to an uncontrollable flood of racing thoughts are typically experiencing highly elevated glutamate levels. Suppressing this specific glutamate spike requires targeted agents like gabapentin. Conversely, if the patient is experiencing highly fragmented, superficial sleep with frequent awakenings, the primary neurochemical culprit is usually an excess of acetylcholine. To aggressively suppress this excess cholinergic activity, clinicians deploy targeted doses of trazodone or doxepin. Premature early awakenings present a completely different chemical profile, a combination of sharply elevated noradrenaline and severely depleted serotonin. Correcting this exact dual imbalance requires agents like clonidine to drop the noradrenergic tone, or mirtazapine to rebalance the serotonergic pathways. By isolating and neutralizing the precise neurochemical driver, clinicians allow the brain to initiate its own sleep cycle naturally, bypassing the need for heavy hypnotics entirely. Tier 2 maps the microarchitecture, highlighting deep N3 slow-wave troughs and REM peaks. Night terrors are strictly an N3 phenomenon, a severe autonomic storm devoid of visual dreams. The patient wakes in panic, having seen nothing. This creates a severe clinical paradox. Drugs like pregabalin normally improve restorative N3 sleep, but for a patient with night terrors, enhancing this phase will actively amplify the attacks. To halt the terrors, a clinician has to make a difficult trade-off. They use clonazepam or tricyclic antidepressants to stabilize or suppress the N3 phase entirely, accepting the loss of slow-wave restoration to eliminate the autonomic storms. Nightmares, by contrast, are an entirely separate pathology, occurring exclusively in the REM phase. REM nightmares are highly visual, structured events driven by severe noradrenergic storms in the brain. Suppressing these localized REM storms requires blocking the alpha-1 adrenoceptors. The blood pressure medication prazosin shows exceptional efficacy for this specific mechanism. However, prazosin requires strict blood pressure titration to avoid orthostatic collapse. Trazodone provides a milder, safer alternative for achieving this alpha-1 blockade. Resolving level 2 parasomnias frequently forces the clinician into this iatrogenic paradox, intentionally suppressing a healthy, vital sleep phase to eliminate a dangerous pathological behavior. Pulling back to Tier 3 reveals the macro level, the circadian cycle, and internal biological clocks. If a patient's biological clock is severely phase-shifted, forcing chemical unconsciousness onto them during their biological day does absolutely nothing to reset their internal rhythm. Standard hypnotics often inflict profound harm. This chart visualizes the robust oscillating sine waves of melatonin, cortisol, and temperature over 24 hours. Benzodiazepines and Z-drugs actively suppress these hormones, flattening the waves into lifeless lines, destroying the natural day-night contrast. Fixing a circadian defect requires targeted chronobiotics that restore this contrast, utilizing agents like melatonin, agomelatonin, or trazodone. Trazodone achieves its chronobiotic effect indirectly by blocking 5-HT7 receptors directly within the suprachiasmatic nucleus, the brain's master clock. But fixing the night is completely impossible without actively anchoring the wake phase to solidify the biological morning. This is why modafinil and armodafinil are prescribed here. They are deployed not as general psychostimulants, but as highly specific daytime circadian anchors. Clinicians can also use metformin to modulate peripheral cellular clocks via energy metabolism, or apply strictly timed low-dose pharmaceutical caffeine to force incremental phase shifts. Resolving Tier 3 defects requires treating both ends of the 24-hour cycle, because sleep architecture is inextricably tethered to waking biological rhythms. When you bring all three diagnostic levels together, the complete clinical picture emerges. This matrix unifies the continuous timeline of Tier 1, the structural hypnogram of Tier 2, and the circadian oscillations of Tier 3. A clinically sound insomnia prescription must be actively cross-referenced against all three of these physiological levels. A drug that successfully forces sleep onset at Tier 1 can inadvertently trigger a violent N3 parasomnia at Tier 2, or completely flatten the necessary hormonal amplitude at Tier 3. This demonstrates the value of versatile drugs. Agents like trazodone or mirtazapine operate safely across all three tiers, addressing surface continuity, neutralizing neurotransmitter imbalances, and anchoring rhythms without disrupting the underlying physiological architecture. By rigorously evaluating the exact point of failure, continuity, architecture, or circadian rhythm, clinicians finally abandon the era of blunt sedation and restore true physiological sleep.